So, good evening, everyone. Today, welcome to Oncology Academic Forum. We welcome Dr. Mohammad Mansoor Mohiuddin, sir. He's a consultant in nuclear medicine at Care Hospital, Hyderabad. And we welcome you, sir. And thank you for giving us your precious time. The topic that will be discussed today is transarterial radioembolization. And over to you, sir. Thank you so much.
Thank you, Navneet. So let me just first share my screen. Yeah. Okay. Today's topic on Oncology Academic Forum is transarterial radioembolization, commonly called as TARE, and another name for it is selective internal radiation therapy, SIRT. And in short, it's just called as radioembolization. Now, this modality is maximum used in treatment of hepatocellular carcinoma. So we will discuss about HCC in brief. It's a very lethal cancer. It's the 5th most common cancer in men, 9th most common cancer in women, the 3rd most common cause of death due to cancer. It's more common in Asia, especially East Asia, Southeast Asia, and Middle East, Middle and Western Africa. It has a poor prognosis due to background of cirrhosis. The incidence of HCC keeps rising every year, and the number of deaths due to hepatocellular carcinoma also increases every year. The pathogenesis of hepatocellular carcinoma, it starts with irritants that cause damage to the hepatocytes. These irritants could be alcohol with contributing factors like smoking or hepatosteatosis, along with diabetes, causing metabolic damage to the liver, chronic viral infections like hepatitis B and C, occupational hazards, exposure to toxins and chemicals, autoimmune disease of the liver. It could be also hereditary, like in Wilson's disease, hemochromatosis, and alpha-1 antitrypsin deficiency. When these irritants cause damage to the liver, there are mutations that occur which lead to alterations in the signal pathways, and they cause cirrhosis, and in course of time they lead to formation of low-grade dysplastic nodules. And when these mutations occur in larger numbers, more and more pathways get altered and finally lead to development of hepatocellular carcinoma. And it's usually multicentric, and in later stages it becomes advanced, infiltrating the adjacent structures as well as metastasizing to distant sites. The staging of hepatocellular carcinoma is the BCLC staging, that's the Barcelona Clinic Liver Cancer staging. And this is the chart that shows us the management guide in HCC. So we have the very early stage and early stage. These patients are very less in number. They comprise only 20 to 30%, and they can receive definitive treatment in terms of resection and transplant. And most of the patients that are diagnosed at a later stage either belong to the intermediate or the late stage HCC. And the treatment options in them are limited, and then they become palliative. So the burden, the disease burden is very high because only a small group of patients fall under the definitive treatment category. And in that too, 30% of the patients fail to receive the definitive treatment because they're either waiting for the liver transplant where their disease progresses, or they don't have access to the proper treatment. And majority of them fall under the palliative care category. So what should be the approach? Because the complexity and the heterogeneity of the disease, which involves various signaling pathways, we have to adopt a similar, we cannot adopt a similar treatment regimen for all patients. That will not be effective, and it would even make the matters worse. So that leads us to a term called personalized treatment approach. And when there are so many treatment modalities available, the definitive ones being resection and transplant and radiofrequency ablation and ethanol injection ablation for smaller nodules in few centimeters in size, then from there we can have a good response, even a good survival of the patients. Then for the intermediate stage, we have the transarterial chemoembolization, the radiation therapy, targeted radionuclide therapy, and then for advanced stage, we have molecular targeted therapy, the epigenetic modification based therapy, or immunotherapy or gene therapy, and at the end we have best supportive care. Now, to select which patient would benefit which therapy, we have to be very precise, and that leads us to the concept of precision medicine. In this lecture, we are going to discuss about targeted radionuclide therapy, and TARE is a part of radionuclide therapy. So coming to TARE, this is a catheter-based treatment approach. It's a multidisciplinary treatment approach where the involvement of interventional radiologist is most important. And then on the background, we have the hepatologist, the gastroenterologist, the oncologist, and the nuclear medicine physician. We all take part in workup and proper selection of the patient, which is the most important in this. So let us begin with the introduction of targeted radionuclide therapy. This is an old concept. It started with radioactive iodine ablation of thyroid cancer since the early 1940s. Here, there is a target on the cell membrane of the cancer cell, to which the ligand can bind, and we label the radioactive isotope to the ligand, and that directs us to the cancer cell, and then it gets internalized. This is how we deliver the radioactive medicine directly to the cancer cell, and that is the reason why it's called targeted radionuclide therapy. And once inside the cell, it causes damage to the DNA either by directly acting on the DNA strands or indirectly by causing hydrolysis of water and production of free radicals. The damage of the DNA can be single-stranded breaks or double-stranded break, or DNA-DNA linkages can be damaged, or the DNA-DNA interaction or DNA to protein interactions are affected. That leads to apoptosis of the cell. Now, to get a good effect of this, we need a proper targeting efficiency. That means that if the labeling efficiency is very good, then the ligand and the radioisotope, they do not get they do not get separated before getting delivered to the cancer cell. And the route of administration, most of the radionuclide therapy that we give is either oral or intravenous. But sometimes is directly, we can deliver it to the tumor by intratumoral injection, or we can deliver it to the tumor by injecting it into the artery that supplies the tumor. And these are various routes of administration. And the biodistribution of the radionuclide is also important. We don't want the radiopharmaceutical to go to the tissues which are healthy and non-tumorous and cause radiation damage there. So we want less biodistribution to other areas and more distribution to the tumor. And bystander effect is the effect of radiation to the neighboring cells that causes damage, and we would definitely like to avoid the bystander effect. And especially in liver, in hepatocellular carcinoma, which occurs in a background of cirrhosis. So there's not much of a healthy tissue remaining behind. So we want less and as less as possible damage to the cirrhotic cells. And the toxic dose that we cannot exceed here would be 30 gray to the normal or the cirrhotic liver, which is non-cancerous. Now, coming to the selective internal radiation therapy, what we use is the unique blood supply of the liver. Here, the normal liver parenchyma gets blood supply from the portal vein and hepatic artery, and maximum portion of this comes from the portal vein, and only 20% is supplied by the hepatic artery. Whereas if you see the tumor, it gets more than 90% of its blood supply directly from the hepatic artery. So we use this principle in selective internal radiation therapy, where we catheterize the feeding hepatic artery to the tumor and deliver all the radioactive medicine directly into the tumor and less to the normal parenchyma. And we can, by this, we can deliver a very high radiation dose to the tumor, which can go up to 90 to 100 grays. So let us look at a few salient points here. In SIRT or TARE, we use yttrium 90 labeled microspheres, and iodine 131 and rhenium 188 lipiodol have also been used. I have slides that will come up later, which will show the other isotopes that have been used in SIRT. And this is a highly targeted approach. We deliver very high radiation dose to the tumor, and thereby we cause shrinkage of the tumor and by the process of apoptosis. And if you compare SIRT with transarterial chemoembolization, here the maximum shrinkage of tumor occurs as a result of embolic effect, which causes ischemia. Whereas in SIRT or TARE, that is the radiation that causes the shrinkage of tumor and not the embolization. And we can use SIRT for lobar ablation also. Later we'll come to know what lobar ablation means. And this is better tolerated compared to TARES with lesser side effects. And the only drawback here is it's very costly. So when to use this? There are guidelines available. The American Society of Clinical Oncology, they were the last to give FDA approval to microsphere therapy. And now the recommendation from 2018 is that every patient who is not a candidate of surgery should be considered for TARE. The European Society of Medical Oncology suggests it's a promising therapeutic option, either as a bridging treatment or as the main therapy for patients with diffuse intrahepatic tumor spread. NCCN guidelines, they recommend the use of TARE is that it's suitable for patients with unresectable disease due to inadequate hepatic reserve, poor performance status, comorbidities, or specific location and extension of the tumor. And National Cancer Institute says it may be considered in selected patients with liver confined HCC who are not eligible for transplant or resection. The procedure in TARE involves proper patient selection and pre-treatment workup. This is the most important step. When we select the correct patient, it gives the maximum benefit. This followed by an angiogram and injection of MA particles in the cath lab. This is the prerequisite for the microsphere therapy. And after injecting MA particles, we assess the hepatopulmonary shunt fraction by doing a SPECT CT scan. We calculate the dose required for that particular session of treatment, and that is followed by taking the patient again to the cath lab and injecting yttrium microspheres, and the exact pathway is laid down in the first angiogram, which selects the arteries that feed the tumor, and those arteries are only targeted, and you directly go catheterize the same vessels and then inject the microspheres. This is followed by PET imaging of yttrium microspheres or microsphere, or you can do a Bremsstrahlung SPECT imaging. This is not an essential step, but it helps to confirm and see the concordance of the distribution of microspheres with the distribution of MAO particles. Now let us see each step in detail. Patient selection. The inclusion criteria is that the patient should have a confirmed diagnosis of unresectable hepatocellular carcinoma, age more than 18 years, with a performance score of less than or equal to 2, and adequate hematological parameters, WBC count less than 1.5, platelet count more than 60,000, and renal function creatinine should be less than 2, and liver function test with a bilirubin level, total bilirubin less than 2. And then we have to assess the ability of the patient to undergo angiography and selective visceral catheterization. Any contraindication to angiography is a contraindication to microsphere therapy. And majority of the patients have a child-pug score of less than or equal to 7, but even though we can select patients who have a score more than 7 for this therapy, and it's not an absolute contraindication. The exclusion criteria, any other liver-directed therapy, if it is planned, then we cannot plan it along with that. And if there is an uncorrectable flow to the gastrointestinal tract, that is an aberrant artery arising from one of the hepatic arteries and supplying the small bowel, that can cause radiation damage to the duodenum or stomach, that makes it a contraindication. And if the lung shunting is more than 20%, that's also a contraindication, as it causes a lot of radiation-induced pneumonitis. And then if there is significant extrahepatic disease, then we don't go for a targeted therapy approach. It's a palliative treatment approach. A pre-treatment imaging involves a volumetric CT scan where you accurately assess the volume of the healthy liver, the volume of the tumor, and if there is an invasion of the portal vein, then you assess the extent of tumor thrombus in the portal vein. And you can also have a very good estimation of the abdominal vascular anatomy before going into the cath lab, and it also serves as a baseline. And many centers use whole body PET scan at this stage, which serves as a baseline and also to assess the disease burden to detect metastasis, but it's not a mandatory scan. How the volume of the liver and the volume of the tumor are calculated, and a very good image that gives us information about the vascular supply of the liver and the vascular supply of the tumor. The next step would be, take the patient to the cath lab and do a hepatic angio, and you study the vascular anatomy, and you see the arteries that directly feed the tumor, and you select. You need to do a hyperselective embolization, the radioembolization. So you select which arteries you need to catheterize and inject the microspheres with, and the same arteries you need to inject the MA particles also, the technetium labeled MA particles. And during this study, we also assess the aberrant arteries that arise from the hepatic arteries and supply the bowel loops. And there can be leakage from the capillaries, the peritumoral capillaries, which is seen as thread and streak sign in the early angiographic phase. And in the late angiography phase, you see the blood flow reaching directly to the portal vein. Now, this is a bad sign in the angiogram, which suggests that there is an arterioportal venous shunt. And with that, what it means is the particles that you're going to inject into the feeder artery are going to bypass the tumor capillaries and reach the portovenous circulation, causing damage to the healthy liver and also to the extrahepatic sites. Now, when we do this angiogram, we have the radiopharmaceutical, the technetium labeled MA, ready in the cath lab, and after selection of the vessels, the interventional radiologist injects about 15 to 30 millicurie of Ma particles into the hepatic artery, and which is later followed by SPECT or SPECT CT imaging. And then what we do is we draw a region of interest around the liver. This is the Ma particles that have accumulated within the tumor in the liver in the right lobe, and we draw a region of interest around the lungs and around the liver, and we calculate the lung shunt fraction by dividing total counts in the lung by the total counts in the lungs plus total counts in the liver. If the fraction is less than 10%, we can go ahead with the full dose of THER. If the fraction is 10 to 15%, we need to reduce the dose by 20%. If it's 10 to 15%, we need to reduce the dose by 20%. If it's 15 to 20%, we need to reduce it by 40%. And if the fraction is more than 20%, we cannot do THER. It's a contraindication. Now, the SPECT scan also helps us to determine the radiation dose that is delivered to the lung. And this is the formula that is used to calculate the radiation delivered to the lung. And if the radiation dose is exceeding 30 gray, then we should not go ahead with the procedure. Now, let us come to the therapy, which is the most important step in THER, that is the administration of microspheres directly into the feeder arteries. That's the second time when the patient is taken to the cath lab. Some introduction about Utm Microspheres. Utm is a pure beta emitter with a half-life of approximately 2.5 days. It has a limited tissue penetration because it is a pure beta emitter. The average penetration is 2.5 mm and the maximum penetration is 11 millimeter. It produces more of radiation effect rather than embolization effect, which we've already seen. And there are two types of microspheres that are available for clinical use, spheres and TheraSpheres. The average number of glass spheres injected in TheraSpheres is 4 million, whereas in spheres it is 40 million. And because their number is less, the TheraSpheres have a lesser embolic effect and more of a radiation effect. And the comparison of these spheres and TheraSpheres in detail, spheres are basically made of resin matrix, whereas TheraSpheres is of glass matrix. And spheres have a larger size compared to TheraSpheres, and the specific activity of TheraSpheres is significantly higher compared to the specific activity of spheres. And the activity per vial in case of spheres does not exceed 3 gigabecquerel, whereas the maximum activity of TheraSpheres goes up to 20 gigabecquerel, and the specific weight of spheres is less compared to TheraSpheres. Now, hypothetically, what we see is TheraSpheres are good in treatment of hepatocellular carcinoma where the tumor size is not large, and since their specific activity is high, you have less particles. Less particles injected, which causes less of reflex and more of stability. But the problem is in larger tumors is the uniform distribution of TheraSpheres is not very well achieved. As you see with spheres, you get a very uniform distribution. But since you have a higher number of particles, it causes more of an embolization effect. So at the time of injecting the particles, you have to be really slow and very stable. And you have to see that there is a quite uniform distribution in the entire tumor to cause a good shrinkage. And calculation of dosimetry in TheraSpheres, we have this formula where we use M is the mass of the whole liver and LSF is the liver shunt fraction. 120 gray is the lethal dose that we want to deliver to the tumor, and assuming that there is uniform distribution of the microspheres. Whereas spheres, we have basically different methods of calculating dosimetry. The first one is empirical method, where the amount of activity injected is in relation to the volume of the liver. If the volume of the tumor is less than 25% of the volume of liver, we inject 2 gigabecquerels. If the volume of tumor is more than 25%, but less than 50% of the volume of liver, we inject 2 to 2.5 gigabecquerels. And if the volume of tumor is more than 50% of the volume of liver, we can inject up to 3 gigabecquerels. Then we have the body surface area method, which is based on the volume of tumor lobe, whole liver volume, and body surface area of the patient. It enables the treatment of different lesions in separate lobes, thereby preserving the healthy tissue. Now, the next one is partition model, which is based on medical internal radiation dosimetry calculations. It takes into consideration the results of mass spec CT, which is based on the distribution of tracer in healthy tissue versus accumulation in the lesions. Now, this is very helpful in patients with a poor liver function. The next dosimetry calculation method is the voxel-based method, where you see the accumulation of Ma radiopharmaceutical voxel by voxel. It is calculated, and this helps us in delivering a high radiation dose to the tumor and giving a less radiation dose to the healthy tissue. So this is the most advanced method available. And the role of SPECT, that is done before therapy, beyond estimation of liver shunt fraction, has been studied, and it has been found that it predicts the treatment response. The more tracer gets accumulated in the tumor, the better response you get, which helps in predicting the progression-free survival, the overall survival, and plays an important role in patient selection and treatment planning. And this indirectly helps in personalization of treatment planning, and this can further be improved by using dual tracer technique, where you inject Ma and you do a sulfur colloid scan fusion SPECT CT, and that gives us a physiological map of the function of the liver. Now, complications that can arise in TARE can be due to those that are the radiation effect to the normal tissue, and the ones that can be due to catheterization, that is formation of a hematoma or damage to the vessels. But the main complications that we encounter there, the incidence is very low. As you see, if it's a proper patient selection and you do the workup properly, you get less radiation effects. So radiation-induced liver damage, the incidence is 4%. Biliary complications, the incidence is less than 10%. And post-radioembolization syndrome, where the patient can develop abdominal pain, nausea, vomiting, and fever. And that is the most important, and that could be 20 to 50%. And this can be reduced by properly selecting the patient with and giving pre-medications, the steroids, the proton pump inhibitors, and antiemetic medication. There can be gastrointestinal complications if a proper angiography is not performed, where you evaluate the aberrant arteries. And the last one is the radiation pneumonitis, and this can be avoided by accurately estimating the lung shunt fraction. Other isotopes that have been used in SIRT or TARE are phosphorus 32, iodine 131, the holmium 166, 177 lutetium, rhenium 186, and rhenium 188. Now, in this table, one point to observe is that you have a gamma ray emission of these isotopes here, and whereas phosphorus 32 and yttrium are pure beta emitters. The beneficial role of this gamma emission is that you have a better imaging after the microspheres have been delivered into the tumor, compared to the beta emitters, where the imaging is not very good. Especially, there is no imaging possible with phosphorus, and with yttrium, you can do a PET scan, you get very low counts. So the particles that have been used before, the phosphorus P32 microspheres, these were the first one used. They've been used in the early 1980s. Holmium 166 microspheres, they are highly paramagnetic. So the advantage with them is you can do an MRI scan, or there are and then we use the polymer-based microspheres. They have a near plasma density, and they are the benefit and the advantage of their biodegradability, biocompatibility helps them. They can be selected as the better choice, and but they cannot withstand the higher thermal neutron fluxes at the time of preparation. So they are used mostly with Holmium-166 and Rhenium-188 microspheres. They have a good tissue penetration like yttrium, and then the lipoidal based iodine-131, Rhenium-188, Lutetium-177, Yttrium-90, and Holmium-166. All of these have been used. Now, let us see what the literature says regarding TARE in early stage hepatocellular carcinoma. Liver transplant in early stage HCC. Liver transplant remains the elective approach for patients with early stage cancer. However, given the paucity of donors, patients often experience disease progression while on waiting list, and therefore bridging therapies are often used to delay the progression, and TARE has been recently proposed in this setting. Unresectable HCC showed similar overall survival at 1 year between TARE and TACE. TARE may be associated with a longer time to progression of HCC compared with TACE, and there is a statistically significant overall survival advantage with TARE compared to TACE. And TARE has a better tolerance compared to TACE. There are lesser side effects. And because TACE causes more of embolization, patient feels more uneasy. There is more of abdominal pain because there is ischemia to the liver, and the nausea, vomiting, and fever. All these complications are very less in TARE compared to TACE. In intermediate stage hepatocellular carcinoma, TARE was associated with longer time to progression, 13.3 months versus 8.4 months, and less incidence of complications. However, there was no difference in overall survival when compared to TACE. There is definitely a lower need of hospitalization. TARE showed a similar efficacy in terms of survival as sorafenib, which is the only medical treatment available for HCC in patients with intermediate stage disease. The percentage tumor shrinkage with TARE showed that there is better outcome compared to TACE. And it's more suitable for patients with large extent of disease and modest residual liver volume. TARE can induce hypertrophy of the treated hepatic lobe, that is the hepatic lobar ablation. And therefore, when there is more disease in one lobe, we radioembolize that lobe, it shrinks, and the other lobe and the caudate lobe undergo hypertrophy, thereby improving liver function. This is the hepatic lobar ablation. In later stage disease, sorafenib is the elective treatment for patients affected here. And in this setting, TARE has been associated with an overall survival of 6 to 10 months, lower than the results reported with sorafenib in clinical practice, suggesting that TARE may be used in treatment of patients who do not respond or are contraindicated to sorafenib treatment. European randomized SORAMEC trial with TARE, followed by sorafenib, is well tolerated as sorafenib alone. The number of total and grade 3 adverse events was similar in combination treatment and control arms respectively. Patients with portal vein thrombosis involving segmental and lobar branches treated with TARE achieved an overall survival of up to 23 months. One important point here is TARE is possible in patients with portal vein thrombosis, whereas TACE is not possible in patients with portal vein thrombosis. Use of TARE in other tumors, it has been used in treatment of intrahepatic mass-forming cholangiocarcinoma, and it has also been used successfully in hepatic metastasis from colorectal carcinoma. So to conclude, SIRT delivers high radiation dose to the hepatic tumor with less toxicity to the healthy tissue. It is better tolerated, however, it is costly. It is effective in early, intermediate, and late stages of the disease. Proper patient selection and meticulous planning is the key. Its use is now also being extended in treatment of intrahepatic mass-forming cholangiocarcinoma and hepatic metastasis from colorectal carcinoma. Now that is the end of our lecture, and I will be happy to take any questions that you have.
Hello.
Yeah, hi.
Yes, sir. So just a second. Hello. Yes.
Yes, Naveen.
Yes. So can you just please say a little about the post radioembolization syndrome, like how to manage and what are the complications of that?
Only supportive care. You give steroids, antiemetic medication, you give pain medication if there is abdominal pain, antipyretics if there is fever. You see less complications in tear compared to taste. So that's all that I know
of. Okay. So are there any other questions from anybody? So please feel free to unmute yourself and ask, or you can also use the chat box. So, sir, like how it's just like a angiography that we do, and then we insert the. How is the insertion done? Like under the
via catheter. It is done via catheter. Yeah.
So after the
same way how you inject chemotherapy in TACE, it's the same way.
And sir, like they dissolve automatically. How like after insertion, what precautions should be taken, and how long the patient should be like, or is it just we insert and the procedure is over? Like how is that done?
No, once you inject, it's over. You don't have to keep the patient under isolation. The most important thing is there should not be any contamination of the radiopharmaceutical at the time of injection. You may see that all the connections of the catheter and the injection, everything, they are connected properly. There is no leakage of medicine at the time of injection, which causes added radiation. There should not be leakage at the insertion site. Yeah, these are the things that are most important. Extravasation of tracer should not be there.
And sir, is there any like case that if suppose extravasation happens, so anything should be done or just abandon the procedure? So what is?
No, you don't abandon it, because the catheter is long. It goes all the way up to the liver. The chances are very less. So if at all, it has to be a damaged catheter if you're seeing extravasation. So that could be due to damage of the vessel. You can see hematoma forming. There is not accumulation of the radiopharmaceutical in that hematoma. But if the connections are loose, then the chances of spillage are there. You just clean the area, and then whatever damage happens, you try to see that you're taking care of that.
And sir, what is the size, maximum size up to which this procedure can be done?
Even more than 10 centimeters, they're doing it now, so it's not a contraindication anymore.
Okay. And
it all depends on the shunt fraction. The tumor size is more, invariably the shunt fraction is more. So if it's more than 20%, you cannot do that.
Okay. And sir, just one last question from my side. So sir, I think there are no more questions from anybody in the chat box. And So it was a wonderful class, sir. We covered all the aspects of this therapy, and we are really thankful to you to have given your precious time to educate us. And we look forward to more classes from you, sir. Thank you so much.
Thank you. I look forward to too, and it was a good opportunity. And I made the presentation uh, s- as discreet as simple as possible, without going into much details, and very brief